Dan Mogila from the Campus Office of Communications and Public Affairs. Forgive us for this late start. We had a few technical difficulties going in, so we'll get started right away. Today, we're going to be talking about and taking questions about the rollout of COVID vaccines, which, as we all know, has been beset by logistical challenges, some confusion, and not a small amount of controversy. With UC Berkeley's own vaccination program now underway, we're hoping to bring a bit more clarity to this complex situation. And to do that, we've gathered some of our leading public health experts and clinicians for today's panel. Guy Nicolette, MD, is the Assistant Vice Chancellor and Leader of University Health Services. Anna Hart, MD, is the Medical Director at University Health Services. Professor Art Reingold, also MD, is the Chair of the Division of Epidemiology at our School of Public Health. Professor John Swartzberg, yet another MD, was with the Division of Infectious Diseases and Vaccinology at the School of Public Health. Now, we already have a large number of questions that have been submitted, but you're more than welcome to post additional queries to the Facebook Live site as we go along. We're going to do our best to get to all of them. But if we don't, we will be posting those questions and answers to the campus coronavirus website, which will also be shared in our response and recovery newsletter. Well, let's get started. We're going to be talking about this in two basic areas or silos, one about the vaccines in general, and two more specifically, the situation on the Berkeley campus. And Guy, I want to start with you and then go around this virtual room, if you will, and have each of you share, where do you think we are? What are the things you're noting? What are the things you're concerned about? A little summary, how you've been processing news and developments on campus and beyond. Guy, please.
Yeah, thanks, Dan. Stepping back just for a second, I think one of the reasons for any amount of success that we've had so far really has been the campus early investment in contact tracing and in testing. And it's really allowed us to get to this point where vaccines are imminent, in fact, here. And even with a little bit of delay or logistic challenges, as you mentioned, we still have set ourselves up to be in a good place as the vaccines roll out. Now, has that been easy, or has it been, completely transparent even to us behind the scenes? No, we don't typically even know, just to give an example, what number of doses we will get any given week. And we usually find out late in the week for that following week. Now that seems to be getting better. And as the state and as local jurisdictions kind of figure out the best process for rolling out this vaccine and distributing it, things will get better and things will get smoother. Even despite having more vaccines to choose from, that will be logistically challenging. But I think we're always learning lessons, and I'm committed to continue to learn the lessons that we must learn and the lessons that are forced upon us, much like we did for the testing. I'll stop there. I've got a lot more to say, but we've got other smart people on the panel.
Yep. Suffice it to say, we'll be back. Art, let me turn to you next and broaden our gaze a little bit to take in sort of the country as a whole, if you will. What's your assessment of what's happening right now, where we stand and where we're headed?
So I think the good news, can you hear me okay?
Sure.
I think the good news is that science has done a remarkable job of getting us to and soon more safe and effective COVID-19 vaccines in a remarkably short period of time without making shortcuts on the safety side. So I think that's the good news. We have vaccines and increasing numbers of doses. Obviously, the challenge is that the bureaucratic complexities of getting doses into arms have been beset by problems. And some of this relates to our attempts to balance equity and reaching high-risk populations of different types on the one hand, and dealing with the fact that fundamentally we may have a federal government, but we have 50 states and multiple territories, and within a state like California, 58 counties and several cities, as well as a lot of organizations that cross county lines, just a whole range of different actors. And so the rollout has been complicated. I'm hopeful it's going to get better, but I am happy to say that at least we have good vaccines to get into people's arms.
Before I go to Anna and John, I want to I want to ask you to unpack something you said, lest anything you say raise questions we don't immediately answer. It seems that you're suggesting there's an inherent tension between equity and perhaps efficiency. Can you unpack what you meant a little bit?
Well, we live in an inequitable society, and Berkeley professors like me can work from home, and I have been working from home for the last 9 months or 10 months. But many of our workers can't do that. The people who grow our food, the people who clean our buildings, the people who provide our police and fire have to be out and about and interacting with people. So they're at intrinsically greater risk of getting infected. And in our society, people who are brown and black are overrepresented among the impoverished and among lower wage workers. So we have an inequitable situation with regard to exposure to the virus, access to good health care, a whole variety of ways. And so on the one hand, we want to protect people who are at greatest risk of getting infected, such as the doctors and nurses working and others working in our healthcare system. On the other hand, we want to try and ensure that communities that are disproportionately affected and traditionally underserved really have access to this vaccine. And so that gets really complicated in terms of trying to balance those different factors.
Super. Thanks so much for filling that in. I appreciate it. Anna, let me come to you next. You're filling some important boots on the ground for the campus in the clinical sense. What are you seeing and what are you forecasting as we proceed?
I'm certainly seeing an enormous amount of interest in vaccine. The number of phone calls and emails and general outreach is wonderful, because I think vaccine hesitancy, while out there, is not the current main problem we have to face. I'm seeing staff pull together to really make this happen. My concern is that the logistical challenges, the bureaucratic challenges do exist. And so Art did say the vaccine is there, but the vaccine is not in our hands right now, despite the fact that we have staff ready and willing to do the vaccination and the systems in place to support it. So the good news is that things are turning a corner, I think. I feel like the new administration, the attention that's being paid to really getting as many vaccines actually out there in the hands of vaccinators as quickly and efficiently as possible is huge now on all levels. And we are working closely with our system, the UC system, and the state to make that happen. But all the best intention and planning doesn't do any good until we actually receive the vaccine. So that's the short version.
So I may have missed something along the way before I go on to John. So I had thought that vaccine supply had already arrived on campus, and it sounds like it is not. When are we expecting it?
So to clarify, we did receive vaccine supply for phase 1A. So we have received so far 700 doses of Mordara vaccine that will be used up by the end of today, I hope. That is specifically for phase 1A, which is associated with healthcare staff. And we will get an additional 200 doses next week. We are not yet allocated for phase 1B. We are hoping that will start the week after next. And so we put in a request through the UC system, which is who distributes vaccine to us. They put in a request to the state, and then we all see what happens. I get a phone call on Friday or Monday saying this is what you're getting. So you can see the challenge.
So, and just to clarify, when you talk about phases, you're not really talking about temporal or timing phases. You're talking about phases in the sense of which parts of our population are eligible to be vaccinated. Do I have that right?
Right, that is right. And the phases are constantly changing. So we base our phasing on the state, the CDPH phases, as well as what we are essentially directed to do by the UC system, which doesn't mean we don't have some influence within that system to negotiate around exactly how we interpret it. So for example, phase 1A, while explicitly directed to give that to healthcare workers or people working in healthcare settings, we were able to vaccinate custodians, drivers, staff working in the quarantine areas, people doing the testing, not just nurses and doctors and medical assistants. So we can work to, and we do work very hard to make sure it's as equitable as possible within that direction, but we don't have full control over who we allocate it to.
Understood. John, have you back cleanup in this initial round. You've been in the public health and that intersection where public health and vaccines meet. What's your assessment of what's happening in the days and forecast for the days ahead? Hold on, you're on mute, John. Can we unmute him, please, Gwen? Thank you.
Unmuted. Sorry. I think the immediate forecast is going to be a rocky road, lots of boulders in the way, as we've already heard about. I think the intermediate forecast is much better, and I think the long-term forecast is actually excellent. Let me explain why I say that. We've had a year's demonstration of what bad governance in the United States can do in the face of a pandemic. The opposite can occur with good governance. And we're now into the third day of a government that is addressing this problem finally. Biden signed more presidential orders in 24 hours than the Trump administration did in a year. So I think the salutary effects of that is going to have a profound effect on the distribution of these vaccines. And in the longer run, hopefully pave the way for more and more vaccines being available. So that's one of the reasons I feel very optimistic about the longer term and the intermediate term.
So I'm going to stick with some general questions about, thank you all so much for those answers in the first round. I'm going to stick sort of at a high level about vaccines in general, and then we'll move into campus specific questions. So a few things that I think that are at kind of the top of the agenda. First, this new word that's invaded our language, variant, new variants of the virus, and there's debate and discussion, and I think some confusion about whether we're looking at the possibility that the vaccines we have won't work, and whether that's something easily correctable. Art, can I ask you to weigh in first on that? How should we process in the context of the vaccine rollout what we're learning and what we're seeing with new variants emerging?
So the coronaviruses are RNA viruses that mutate quite quickly, and it's fully to be expected that they will spin off variants with regularity. And so that's not surprising. What clearly is concerning would be, well, first of all, there seems to be evidence that some of them are more readily transmissible than others. But the other two concerns would be, are they more likely to make you very sick and to kill you? That is, are they more pathogenic? But with regard to the vaccine, the key question is, would this reduce the effectiveness of the vaccine? So if we have a new variant causing a lot of infections, would the vaccine be equally effective against that variant or some other new variants? And so far, the initial evidence is that the variants we've seen are not likely to be associated with a lower vaccine effectiveness, but it's certainly a concern going forward. And I suppose the related, somewhat good news is that at least these mRNA technologies that have been used to make the two current vaccines could be quite quickly adapted, and vaccines against other variants could be made quite quickly.
So how worried should we be? Help me out here. Should I be losing sleep, or do you think that the technology is going to allow vaccines to evolve in concert with how the virus itself is evolving?
Well, as I said, I think the technology will allow that, but you should be concerned.
John, anything you'd like to add to that?
Yeah, I agree with what Art was saying, but let me add a perspective to that. What were you worried about last October and in the first week of November? We were all worried about whether we'd even have a vaccine. Would a vaccine work? The FDA said they'd approve a vaccine if it had 50% efficacy. I was hoping for 70%. And we had our socks knocked off when we heard that these Moderna and Pfizer were 94, 95% efficacious in at least the population below 65, and not much less than that in the older population. So while these variants are of concern, and of course we have to look at them carefully and we have to study them more robustly and identify more of them than we've been doing here in the United States in the past, let's look on the positive side. We have vaccines that I don't think any of us guessed would be this robust, this effective, and this quickly.
And if I can just jump in, just from the clinical, adding a clinical perspective, that immunity is a bit on a gradient. Not everybody that gets a vaccine, even a very effective vaccine, is going to be fully protected. It really does appear to be somewhat on a gradient. And obviously the gold standard we would want is some sort of sterilizing immunity, some neutralizing antibodies that completely take care of an infection before it even sets up in a human host. And that's just not how it, that's just not been our experience with these kinds of vaccines and immune responses, that there really will be people on a gradient. And so, and correct me if I'm wrong, please, John or Art, but with the 95% number that's been thrown out, I think what we're talking about is 95% effectiveness against symptomatic infection, and it's lower in the asymptomatic, for the asymptomatic infection. And of course, it's very difficult to pick up asymptomatic infection unless you're testing for it. And so, this, even a fantastic vaccine like this, if 95% is the number, is still not going to protect everybody in every single situation. And it's not going to, we're not sure, there isn't evidence yet to know whether it protects against asymptomatic transmission of that infection. So I may get a vaccine and look like I'm fully protected, but it's possible that I could still, in a sense, harbor and transmit an infection. So there's lots of, that sounded really negative, and I'm very, very positive about this vaccine, but there's a lot of perspectives and a lot of elements to this that I think are helpful in the larger discussion.
Can I add one word too, Dan, please? Which is that there's two reactions I have to that. I agree with everything that's been said. One is, people, I don't think, realize that most vaccines are nowhere near that effective, and this is astounding. And I actually got some calls of people saying, well, why should I get it if it's not 100% effective? And that doesn't exist. There is no such thing. I am extremely confident in this vaccine. I don't think we know yet, really, actually, how much it really prevents asymptomatic infection. They're just beginning to collect that, release that data soon, I hope. The downside to all this is it's why it's so incredibly critical. We're in this critical phase right now where we don't let down our guard too soon. One of the things that we have to work with here is a lot of questions. Well, can I stop testing? Can I stop doing these different things? And the answer is an absolute no, don't change a thing right now. There are so many things that we still need to figure out. So we're at this tipping point, really, even if we have the vaccine, that we not launch too fast into an assumption that the infection is no longer out there.
So I always want to follow up and make sure I understand it. Everybody who's watching now understands. When you talk about asymptomatic infection, you're saying that you can get the vaccine, you can still be infected, but you won't actually get sick. And you could still be contagious. So in terms of personal benefit, you're not going to get ill. You'll be protected, but you could still make somebody else ill, and you could still be infected. Do I have that right?
That's pretty much the issue, and we will be learning answers to these questions over the near term. But it is, in theory, possible that you could be protected yourself, but still capable of becoming infected and infecting others.
Got it. Sorry, John, did you want to say something?
Well, there's just another way to think about this. What we're talking about in terms of protecting ourselves is what's called functional immunity. That is, we can get infected, we don't get sick, but we still can spread it to other people. The other end of the pole is sterilizing immunity, which means you can't get infected and you certainly can't get sick. And it's not a binary question. It doesn't mean it's either sterilizing or functional. It's going to be somewhere along that spectrum. And what we're all hoping for, and there's reason to be optimistic, is that it's going to be tilting more towards the sterilizing end of that. But I want to really emphasize exactly what Anna was saying is, until we can answer that question of where we are along this spectrum, those masks stay on, we still social distance. even after we're vaccinated.
Got it. And I want to circle back to, you were talking about how astounding, and I'm going to ask the rest of you to sort of pitch in after Anna responds, how astounding the development was, the technology was, the speed of which the vaccine was delivered. But I think one could say there's also sort of a flip side to that, which is questions about safety have only increased because, as somebody asked, how can the safety of this vaccine be ensured without proper safety trials when the technology has never been used before? And all this comes on top of some latent resistance and concern about vaccines in this country. What percentage of the population remains unclear? So talk to us a little bit about how you assess the safety and why we should feel confident about something that feels like it was rushed to market so quickly.
That's a really good question. I'll start, then I definitely think we need to hear from some others here who have been very much involved in the assessment of safety. So what we do have is really, really good short-term data, right? So there have been huge trials of the use of these vaccines that have been shared out publicly. And the FDA EUA approval, the emergency use authorization, is based on those results. We have thousands and thousands of people who have received these vaccines already, which means we can speak very well to the very immediate concerns around safety. The risk of anaphylaxis, which is in the news, it's in the news, but last I heard it was around 1 in 100,000 vaccine recipients.
Wait, so sorry to interrupt, you're talking about an extreme allergic reaction?
Right. So we do have good information about that, which doesn't mean we're not going to continue to learn. What we don't have is long-term information because it's just too soon. So right now it's a question of weighing of risk benefit of immediate risk and immediate benefit. The immediate risk right now is there is widespread transmission of COVID in our community. We all have people around us who are at risk. There's no question in my mind right now that the benefit of vaccination outweighs any theoretical risk about long-term, but we don't know that yet.
Got it.
One thing I would add is that just to speak to a very specific safety question that I've gotten, and I suspect others have, is, it's an mRNA vaccine. Does that somehow change my DNA? Are we really messing with the genetic code? And the answer is no. So I think anybody worried about their own DNA or genetic code is not a reason to avoid getting vaccinated. I'd love to hear.
So
I just want to say I'm keeping track of the good news, not messing with genetic code. Okay, good. Art?
So let me just put in a couple of other comments relating to this. So first of all, in addition to the people who participated in the trials, on whom there are very good short-term data about safety, the CDC in fact published today an MMWR with information from one of the ways we monitor vaccine safety once we're giving the vaccines to large numbers of people, reporting on over 1 million recipients of the vaccine. And in fact, the severe allergic reactions, the anaphylaxis in that report, are just more in line with other vaccines, about 1.5 per million, and not 1 in 100,000. So people should know that these are being monitored carefully. The short-term safety data look quite good and compatible with other vaccines. But I think I want to disabuse people of this notion about that somehow, because we don't have long-term safety data, quote unquote, this vaccine is different. We have never had what you might call long-term safety data. That is to say, will the vaccine give me Alzheimer's in 20 or 30 years? Will it increase my risk of breast cancer in a decade? We've never had that kind of information about any vaccine that we use. And in fact, there are epidemiologic reasons why it's extremely difficult to even conceptualize collecting such data. So the notion that people have that until I know that this won't do something bad to me decades from now, is simply not a realistic standard or one we've imposed on other vaccines or medications for that matter.
John?
Yeah, a couple of additional things. The first is these mRNA vaccines. This is the first time we've used them in a mass distribution to a population. That's true, but Art and I were in correspondence this morning with our colleague Lee Riley, who points out that For 3 decades, we've been experimenting with mRNA vaccines in animals and in humans, albeit in smaller numbers, and we haven't seen any long-term bad effects. So that's, I think, an important piece of information that isn't widely known. The second thing is that if you look at side effects from vaccines, consequences of vaccines in general, not necessarily these, almost all of the serious side effects, you could essentially say all of the serious side effects are going to be found within the first 2 months after they've been given to people. It's possible, as Art was saying, that something could happen much longer than that, but almost all of the serious side effects occur within 2 months. And these vaccines have much more than 2 months of data on them. So I think that's another support to this, what Anna and Guy and Art are saying.
Got it. We're going to turn to the campus in particular in just a second, but just a couple of more general questions. And John, I want to stay with you here. We've been talking about, the 2 vaccines that are currently available for distribution in the United States, the Moderna and the Pfizer vaccines, but we know more are in the works. Are there more traditional vaccines coming? When do you anticipate that we'll be seeing, additional supply? What does it mean that they're using different technologies? Cast your eyes ahead a little bit, because tell us if we're being realistic to expect the arrival of more vaccines and whether that's going to change the picture.
It is realistic to expect the arrival of more vaccines. We've got at least 6 different platforms or different ways we're making vaccines. We've already talked about the mRNA vaccines. The next ones coming up are going to be a different platform using a virus called adenovirus that's innocuous in humans, but it's our vector for vaccinating us. The Johnson & Johnson Janssen vaccine is likely to complete their phase 3 trial and submit the data to the FDA by the end of this month. It'll probably take the FDA about 2 weeks to give it an AUA if the data is convincing. And there's every indication we have so far with the phase 1 and 2 trials that the data should be very good. After it receives an EUA, we'll be able to use that vaccine. Unfortunately, there's going to be a delay in Janssen, J&J getting that vaccine out to the public. It could be, I think realistically, we're talking about sometime late in March, maybe mid-March if we're lucky, and maybe it's going to be early April. But on the heels of that is going to be the AstraZeneca Oxford vaccine that we've already heard something about. And that's probably going to have their phase 3 trial completed and submitted to the FDA either at the end of February or very early March. Again, 2 weeks after that, it would be approved. And they're going to be able to scale up more quickly because it's already in use in many other countries, including Europe. And then on the heels of that is the Novovax vaccine, which is an entirely different platform, a third different way of getting us immune to that spike protein, which is what we want to accomplish. And that we should have some results in terms of a phase 3 trial in April. So it's great that we have 3 different platforms, and there are, as I mentioned, 2 or 3 more platforms that are being developed for these vaccines. And I think that's a healthy way to develop this market. We have no idea what's going to turn out to be the best. Maybe this will turn out to be like the measles vaccine that gives 93, 94% protection that's sterilizing completely. I don't think we're going to see that, but you can always hope for it. I didn't think we were going to see, as I said earlier, that we'd have something better than 50%.
Thanks. Let's turn to the campus now. We got a lot of questions that have come in. Our audience consists of members of the campus community. So Guy and Anna, I'm going to mostly turn to you, but please, John and Art, to the extent you want to add in, just jump on in. So first, let's just start with the basic. One of the questions is, can you please describe the tier program and vaccine rollout plan for the campus and the expected timeline for staff, students, and faculty?
The timeline we probably ought to save for the second half of the answer because, to be blunt, we don't know. A lot hinges on each allocation and each step of the allocation. Like John, I think we're optimistic that the change in leadership might allow for vaccination distribution with a higher priority and a bit more clarity. But again, right now we don't have that. So I'll turn over to Anna the tier system, but essentially, as she said, we follow CDPH system of tiers, which are widely available, and we could link to that into either the chat function or into the document that you talked about later, Dan.
We don't have a chat function, so I'll be referring everybody who's watching and listening.
Dan, you went on mute, by the way.
Yeah, this is some odd things happening technically on this particular event. Sorry about that. I didn't do a thing. We'll be posting additional information. We'll be posting information about the tiers, which sort of lists different parts of our population and when they're eligible. But what's the basic plan, Anna? Who are we privileging? Is it by age? Is it frontline workers? I mean, people out there want to know, in general, how are we making these decisions? What are the guidelines and values?
Yeah. The first thing I would say is the value. The value that we have is to get as many vaccines out there as quickly as possible into as many people as possible, guided by these tiers and phases, but applied in an equitable way. And that's difficult. That sounds easy, but it's very difficult. So I really understand that everybody wants to know when they can get the vaccine. I think everybody is asking that question.
I want to stop you because we use that word equitable, and I want to make sure we're on the same page about what it means. But when I hear you say that, I seem to think, like, how do you measure who would go first? Somebody who's older, or somebody who's a frontline worker, or somebody who is from a demographic group that is overrepresented, or somebody who has comorbidities. Is that what you mean by equity? And if so, who decides who's more important? Somebody with a pre-existing condition or somebody who's 75? Do I have it right? And how do we work through that?
I'll cut to the chase and say that we have a task force here at UC Berkeley that has been working since December to try to make these decisions based on what we hear from the people we get the vaccine from, which is the UC Office of the President and the state guidelines, and of course the CDC and what they're saying in the background. We are held accountable to following those guidelines to some degree. So we are not the designers of the phases or the tiers. Those come down to us and they change all the time. As people know, CDPH phases were changed about a week ago, and we expect they're probably going to change again within the next couple of days. And we are held accountable to and only receive vaccine if we align our practice with those phases and tiers. So when I say equitable, it means that our task force takes those recommendations and requirements and try to apply them in a way that takes into consideration what we know about our campus and the people that work on our campus. So for example, people may have seen the state phase 1B guidelines that are currently posted have made a decision about which essential workers fall into which category or which tier. And they actually leave out some people that we know are working on our campus who are extremely high risk of exposure to the virus. Somebody outside of this campus made a decision that, for example, dining workers in one category, childcare providers are in another, and researchers working with live virus in another. We do engage with those conversations, but we also get to say, okay, but here we have this vaccine, and now let's think very carefully about applying what I was just saying, I think of as an equity lens. So for example, I talked about phase 1. The guidelines say give it to healthcare workers. We thought, okay, who is cleaning the rooms that we have our students in who have COVID? Who is driving them back and forth on the weekends? Who is involved in testing the wastewater out there that we're monitoring for the COVID? And we were able to use our own judgment to apply that guidance. But it's a lot of back and forth. It changes all the time. And that's why we have a group of people, including several of the people on this call, but also a student, bioethicist, some other people to help us do the best we can to make sure that we're considering people's also living situations, multi-generational households, populations that have difficult access to care, et cetera. And it is a huge challenge. Then I'll say also this big question that's current is age versus role. There are basically two paths to vaccine allocation. One is based on the work that you do, how much you're likely to be infected through the work that you are required to do, and in turn infect others. And then there's the other path, which is how likely are you to get extremely ill if you get infected? And those are a little bit in conflict in some ways, as we were talking about in the beginning. We will take what we get from the state and we will apply that. So I will be transparent and say my first pass answer to that question is take those who are most at high risk of exposure, the frontline workers who are 65 and older, combine them. That's one way. If we have only 200 doses, that's who I'm going to be looking to first. But we are meeting weekly to try to chew through that, and we are going to post our decision making as we go on our website.
So I'm gonna open it up to the rest of you, but Anna, forgive me, I'm gonna keep you in the hot seat because I understood, and I think we all understood what you were saying at a high level, but I want to take you down into the weeds with a very specific question that came in from a member of audience that I think will help you sort of apply what you said to a very specific situation. And let me read the question. Why do campus leaders refuse to include UC Berkeley, quote, essential workers who respond to campus emergencies, facilities, EH&S, clean all the buildings, custodians, and keep the campus running maintenance staff in Group 1B for high priority vaccinations? In other words, why aren't these people included in 1B? They meet the criteria of 1B, and campus leadership certainly expects them to put their lives at risk. Yet when it comes to vaccination priority, these workers are sent to the back of the line. So there we have it, all what we're talking about brought to bear in a single question. And your answer.
Very happy to answer that, which is they're not in the back of the line. There is no question in my mind that those people are in the front of the line as far as role is concerned. But again, the role versus the age and medical background are still somewhat in conflict. And there's probably missing a few. So I don't want to imply there may not be others who are high up on the list in terms of their role.
Got it.
And I think I would just add to that real quickly that, we've embedded in Anna's answer, but I want to kind of highlight it, is that we're also thinking about kind of residents in vulnerable communities. That really, to me, it's those paths plus that as an overlay, and it makes for a complicated algorithm. We're trying to drive that algorithm. We're trying to establish it, but it does make for complications, especially when we only get 200 doses or 300 doses, when we know that's not enough to even hit any one group. And then we're really kind of thinking through how to equitably split those so that people in different groups are protected and feel that we've done the best we can to deliver vaccines.
Guy, who is the ethicist from campus who's advising that group that's working on all this?
I knew you were going to ask me that. I'm very good at pronouncing his first name, and I won't right now attempt his last name. Osagi is his first name. He has a joint appointment through the School of Public Health and through UCSF.
Would either of his faculty colleagues like to help us with Osagi's last name? Go ahead, John.
Obaguchi. I may not be pronouncing it correctly.
Okay, thank you. I just wanted to know. So how are we going to find out? And our guy, as members of the campus community, we're going to get an email, a text, your time is up, come on down. How does that all work?
Very good question. Sorry, Guy. Right now, in the early stages, it's an on-the-ground effort where we are reaching out to people by email and cell. But we're building a platform that will be much more outward facing, so that what we're expecting to be able to do is to contact people by email, share a code and instructions to schedule themselves online. There's, as you can imagine, an enormous amount of complexity in the IT side of things, the privacy, the regulatory, and the background. But right now we are literally doing it by email and cell.
And how are you making sure that people sort of descending on a central location that doesn't become lining up for a vaccine doesn't become a super spreader event?
Excellent question. And very top of my worry list all the time. Operating any mass event in a pandemic is quite something, but of course is also part of what inevitably happens. So we're keeping as much as possible outside, and of course ventilation and all of the usual infection control measures are taken and reviewed and continually improved. We get biosafety officers in here. We are scheduling people so that we don't have lots of people show up at once. We have people working lines, making sure people are following rules, people spread apart, most importantly. We have to watch people by regulation for a certain period of time after vaccination. We're moving them outside under tents right now in the rain to sit on chairs, and we're talking with them. So there's a lot that goes in, and a lot of people who are making sure this is done as safely as possible. And we have some tentative plans for larger vaccine space, assuming we get more vaccines weekly starting in a couple of weeks.
And I'll point out, Dan, that we were worried about this with testing, right? The last thing we would want to do is mass test the campus, particularly in the fall, and create a super spreader event. So I think we've gotten very good at organizing kind of these mass events, trying to keep people safe. And to my knowledge, we have not had one single transmission as a result of the testing. And I expect the same with vaccination, that we will have minimal, if any, transmission there, because we've been very thoughtful about how we space them out.
Super. So I want to turn to John and Art with my next question, but before I do, Guy, just I want to confirm something quickly, that we so far have access or have received only the Mordara vaccine. Do I have that right?
That's correct.
All right. So, and this is, I'm sort of going to synthesize a few questions, similar related questions for John and Art. Should people be thinking about how to choose between the two? Is there a qualitative difference? Is there a difference in anticipated side effects? Should people be holding out and waiting for some of the vaccines that are still in the pipeline because they might be safer or have fewer allergic reactions? Or should we just take whatever the heck is on offer?
I can tell you what I did.
That's good.
I took whatever was available to me, and I take the first thing that I could get.
And I will too, if and when I'm offered it. I think in terms of side effects and efficacy of the two current vaccines, they're quite comparable. And so I really don't think one needs to worry about which one is getting. There's a difference in the interval between the first and second dose by a week of what's recommended. But other than that, there's really not much to choose from at the moment.
So it sounds like you're both saying really no significant differences between the Pfizer and Mordara vaccines, and no reason at the moment to anticipate that vaccines in the pipeline will be safer or have fewer side effects?
Well, some of the vaccines in the pipeline will be a single dose rather than two doses. So there will be at least that difference once those come up.
Got it. John?
You have to balance the idea of waiting with the risk of waiting. That is, you don't want to wind up with COVID and be in the hospital, or God forbid, even worse, because you wanted to wait for a future vaccine. These two vaccines, Moderna and Pfizer, set a very high bar for the vaccines that will follow.
Got it.
And Dan, I would just say for campus, what we're telling people is not to wait. If you have access to a vaccine and you would be eligible under our rubric to receive a vaccine through UHS, don't wait. I think I've said this before. I think our people I am very proud of our people, and we deliver the vaccines in the best way, most controlled way, and have great nurses and clinicians doing it better than anybody else. That said, it is the exact same vaccine that somebody else would get elsewhere. So please just go get it. Don't wait on us if you've got access somewhere else.
So speaking about just go get it, we have a few questions along these lines. We've read about certain distribution points where there's extra vaccine. They, for whatever the reason, have been unable to distribute it, and some of it's going to waste. Is there a way for people to find out where those places are and say, I'm good, how about me?
That's a
I
really
haven't
good
heard of that.
question. I can say that we have our own little internal process that we're figuring out here, where essentially we're doing some thinking ahead to who's next in line, and we're getting their cell numbers, and we're telling them you might get a call at the end of the day saying get in here within 30 minutes so that we don't waste any doses. But your broader question, I have not yet seen a way to find that data. I would love it if anyone else has that answer, and we'll post it on our website if we find it.
I see Art shaking his head. John?
Yeah, I think this is a reflection that goes back to what I was talking about at the beginning, and that is we didn't put enough effort into and enough money into the distribution of these vaccines. We put all the money into development, which the Trump administration deserves credit for, but that was 50% of the problem. The other 50% of the problem is getting it into people's arms. There is going to be money coming now. The Congress allocated money about 2.5 weeks ago, and Biden's asking for a lot more, and that's going to help a great deal. But the idea that right now smart people have to spend hours and sometimes days on the phone to try and find out where they can get vaccinated is patently absurd, and just reflects a failure of the system right now.
So let me follow up on that. John and Art, you have both had some fairly tough words for the previous administration. Do you think the Biden administration has gotten it right so far, or are there additional steps you wish they had taken or would like to see in the days ahead? How are they doing, and what do you think of the plan? Art?
So I think the plan looks quite good. We'll see how the implementation goes, because it's going to cost money. And, setting up large vaccination sites at the Coliseum or wherever, requires trained individuals. It requires planning, not to have super spreader events and everything else. So websites that won't crash. There are all kinds of things that are needed.
John?
Yeah, I completely agree with what Art said. We should take even a higher view of this problem and recognize that public health has been horrifically underfunded for decades in this country. And we don't have the infrastructure or the personnel. We have fabulous personnel, but not enough of them. And that's just two of many things we don't have that we should have. We were completely underprepared for this pandemic. From the virus's standpoint, it came at a perfect time when we had a terrible president, and we had a completely unsupported for decades public health system. So I'm optimistic with what the new administration can do. I'm sure they'll stumble like every human being stumbles, but I think the plan they put together, I completely agree with what Art said.
Got it. Thank you. Anna, we're going to come back to campus. We've had a couple of questions. I'm going to bundle them together about students. Let me just read them, if you will. Considering the spikes in case numbers originating in fraternities last semester and the large number of students, particularly low-income students, students of color, who live in congregate living settings, is there any consideration of designating students in group living situations as a priority group for vaccination? If not, why not?
The short answer is yes. We're considering all sorts of things. I mentioned in the beginning that the risk of infection and risk of transmission to others is part of the consideration for whom we put where, and also that we have to follow the rules that we are given and the allocation rule that we are given. So currently, the initial phases of 1B do not speak to that risk. There is a sub piece around congregate living, but it's really focused on people who live in settings where there's also a lot of folks who are at high risk of getting severely ill, like, for example, skilled nursing facility and jails. But we are very, I'm not going to say painfully, we are fortunately aware of the risks that exist within some of our local congregate settings, and we will be applying that to make sure that we try to get vaccines in those directions as quickly as possible as well. I don't expect that will be within the next couple of weeks, to be blunt, just based on what I'm hearing from the state, but it will be part of our conversation every single week at the task force.
So I'm going to turn that question inside out, and it's related, but I think you'll see it's slightly different. So this question somebody sent in says, upon vaccination, will students be able to congregate once again? How will in-person instruction operate if post-vaccination instructions advise to socially distance and wear masks? Meaning, I think this is another question, if I would boil it down, saying, after vaccination, can we just return to life as normal on campus or begin to and have people come together? Guy, do you want to take that one?
Well, I mean, the short answer is no, not yet. Detailed in great ways before by the panel here. The other thing I will point out is that vaccination, at least with the vaccines that we have right now, is a 2-dose schedule, and that typically vaccines take at least a couple of weeks to demonstrate, for the person vaccinated to demonstrate some amount of protection. So we're still at the very beginning, the start of this vaccination process. And I really don't think the spring for students, specifically for students, this answer is going to look anything like what they remember as old normal, or certainly whatever our new normal is, that this spring will look a lot like fall, in that people are we're still asking them to physically distance. We're still asking them to have masks on campus, not asking them, that is a mandate. And we will still be doing quite a bit of testing.
So speaking of mandates, guys, somebody has asked here about whether the campus will require COVID vaccination as a condition of employment. Will that be something people have to get if they want to come back to work on campus?
I know both the campus and the system are wrestling with that issue right now. There's some legal interpretation, and kind of the legal aspect of this is that these vaccines operate under an EUA, and without full FDA approval, there's some legal reasons not to mandate that. It's not an absolute. I don't believe that, said another way, I believe the campus or the system could mandate that, and I think that's being discussed, but I don't know that there's any forward movement on that, certainly not for the short term. We're trying to just concentrate on the distribution and delivery of these vaccines, and in essence require only a statement of acceptance or declination. So that's the only requirement that the system has at this point.
We only have a couple of more minutes, so I'm going to bounce just some short questions, maybe not short, but I want to bounce back to sort of the broader subject for John or Art. Somebody has asked if you can comment on the MIT study, which suggested that certain vaccines may not be as efficient for Black and Asian people. Do either of you have familiarity with that study and can comment on it?
What I will tell you is that we have experience with many vaccines, and there really are no data suggesting that there are racial or ethnic differences in the effectiveness. So I don't have any reason to think that'll be true for these vaccines.
The Mordara vaccine did break out in their study some data on ethnicity, although it's not as robust as we'd like to see. There was no evidence of a different response in Caucasians, Asians, African Americans, and Latinx population. As Art said, I don't anticipate seeing that. I'm not familiar with an MIT study that said that was not the case.
Well, I am familiar with the study, and it's basically a theoretical study relating to HLA type. And as I've said, the experience is, frankly, there is no vaccine where we've seen those types of differences.
So we have time for one more question, and this may be something for all of you. I'm not sure, Art and John, to the extent to which you've been involved with campus policy making, but somebody asked, and I think it's an important question, is there adequate oversight among departments to make sure there aren't people wrongly jumping the line to get vaccinated, like what occurred, according to the questioner, at Stanford, Columbia, and NYU, as reported in the New York Times? What can we say, Guy, let me start with you. What can we say to assure people, not just that we're looking at this through an equity lens, but there's also sufficient oversight about what we're doing and sufficient transparency?
Yeah, as Anna mentioned, we are trying to communicate as regularly as we can, and we're going to have dedicated aspects of the website that not only show what we've done, but where we're headed, to the extent we reasonably can, given all the uncertainty we've already discussed. You know, from the oversight perspective, that's what this task force is charged with, really, is making sure that we have outlined the tiers, the who, the when, and I don't think I can go on record and say that that some employee won't be presented as a part of a group that isn't, or I don't know that we're going to be a 100% effective in making sure that someone hasn't, in quotes, jumped the line, but I just don't see that happening here. Like has been described elsewhere, we have a pretty good system in place right now, and it will only get better as we start to drill down on some of the people and culture reports and data. Anna, do you have anything to add to that?
No, well, yes, I guess I'll say we will make mistakes. It's going to happen. It's not going to be perfect. We're going to all do the best we can, and to ask for forgiveness if things happen. I feel very confident, however, in our process right now. I know that we are all working really hard to ensure that nobody does jump that line. I'm pretty bloody-minded about that. So we will do our absolute best and ask for forgiveness. And we are going to, as Guy mentioned, be posting more information about the algorithm that we're using, which is evolving, hopefully next week.
Can I just point out that Guy and Anna control vaccines administered by the campus, but many of us have access to vaccination through our private healthcare provider. I can tell you that John Muir Health and Kaiser are not doing it exactly the same. And I heard from a colleague yesterday who's about my age, a faculty member, who said he got vaccinated. I didn't ask him where, but there may be apparent discrepancies that have nothing to do with campus policy.
Got it. So go, John, go ahead. Last comment, then we have to close.
Okay. In reference to what's happening on campus and all the issues about getting the vaccine out to people and how it's going to be done and the ethics and so on, I can't think of two people who I would prefer to have in charge of that than Anna and Guy.
That is a lovely way to end this hour and really, I would say we're thankful and grateful to have all four of you, to have your expertise at our fingertips, if you will, for your time and energy and willingness to take on complicated questions. As I noted at the beginning, the questions we didn't have time to answer, we'll be posting those to the campus COVID site. We'll be sharing them in a future recovery newsletter. And again, I want to thank you all and wish all of you tuned in today a good weekend, and that you stay safe and be well. Vaccinations are clearly on the way. Take care.